So, ladies and gentlemen, dear colleagues and friends, thank you very much for the invitation, Renee, and for being able to present here. It's a real pleasure and an honor to speak at this conference in Basel, where the overall theme is Heart, Brain, and Spirit, a holistic approach to modern healthcare. My title is Theological Reflections on Health, Brain, and Spirit, a holistic anthropology. And I speak to you as a theologian, but as one who has for many years worked close to medicine, public health, psychology, psychiatry, and not the least, spiritual care. My aim is not to defend a confessional system, nor to ask clinicians to become theologians. My purpose is more modest and I hope more useful, to show that theology contains a rich understanding of the human person, which may still continue to contribute to modern healthcare. In particular, I speak from the perspective of what is called theological anthropology, the perspective that theology brings to the understanding of the human person, the perspective of the whole person imbued with inherent dignity and worth that no one can take away from the human person. My basic claim is very simple. If we want a truly holistic anthropology, we must resist every reduction of the human person to one level of reality only. Human beings are not merely bodies, not merely brains, not merely minds, not merely social roles, and not merely spiritual seekers. We are embodied, relational, we are vulnerable, and we are meaning-seeking beings. In classical theological language, one might say that the human being lives through body, mind, heart, and spirit in one inseparable whole from creation. From the other side of the river, modern medicine has been extraordinarily successful because it learned to focus, to analyze, to measure, and intervene with precision. And for this, we should obviously be incredibly grateful. But every great success produces its own temptation. And here, the temptation is reductionism. When what can be measured becomes confused with all that is real. When the brain is taken to exhaust the person, when systems eclipse biography, when function eclipses meaning, and when cure overshadows healing. Theology cannot replace medicine, but it can remind medicine that the person in front of us is always more than the disease, more than the organ, and more than the data. I will develop this argument in 7 steps. First, holistic anthropology, then the perspective on heart, brain, and spirit, then the unity of the person, illness as fragmentation, and healing as reintegration. And finally, some practical implications for healthcare and for research. First, why holistic anthropology matters. In healthcare today, the word holistic is used very frequently. Sometimes it is used carefully. Sometimes it is used rather loosely. But behind the word lies a real concern, the fear that the human being is being fragmented by the very systems designed to help. The cardiologist sees the heart, The neurologist sees the brain. The psychiatrist sees affect, trauma, and behavior. The nurse often sees the whole daily suffering person. And the chaplain hears the question nobody else had time to ask. And the patient experiences all of this at once. This is one reason why the holistic ideal remains so important. Human life is not lived in separate departments. Human beings do not suffer in disciplines. A person may have heart failure, insomnia, grief, family conflict, fear of death, and a crisis of meaning. And most of this will be at the same time. Often this is the rule rather than the exception. So the move from a narrow biomedical model to a biopsychosocial model was already a major correction. The latter addition of the spiritual dimension was another important step. Yet even the term biopsychosocial spiritual can remain additive. It may suggest that the human being consists of layers simply placed beside each other. Theology invites us to go one step further. A theological anthropology asks not only what dimensions does a person have, it asks rather, what kind of being is the human person if body, thought, conscience, relation, suffering, hope, and transcendence belong together? If this all belongs together, what kind of person is the human person really? Theological anthropology is therefore not only about adding religion to medicine, it is about understanding personhood itself. And from a classical Christian perspective, the human being is not a machine with a religious supplement, nor is it a soul temporarily trapped in a body. The human being is a unity, finite and vulnerable, yet open to truth, to goodness, to beauty, love, and God. We are biological, psychological, social, and spiritual, but never only one of these, always all. The theological task then is to resist two opposite mistakes. The first is material reductionism, the idea that the human person is in the end nothing but neural and biochemical events. The second is spiritual abstraction, the idea that the body is secondary and that authentic healing concerns only an inner spiritual sphere. Both of these positions are wrong. And classical theology rejects both. It insists on embodiment and it insists on transcendence at the same time. That combination is still deeply relevant to healthcare. The clinic necessarily separates functions in order to understand them, but the patient never experiences himself or herself as a set of separable functions. The patient experiences illness as something happening to me. And that small word, me, contains the whole anthropological problem. It contains memory, identity, fear, shame, gratitude, and hope at the same time. Second, the heart, more than an organ, but more than a metaphor. Let me begin with the heart of this triad. In modern medicine, the heart is, of course, a physiological organ. Pumps blood, sustains circulation, and its failure has dramatic consequences for the entire organism. We know a great deal about the heart medically, and that knowledge saves lives every day. But in the theological and biblical traditions, the heart means far more than the circulatory organ. It is not merely the space and place of emotions in the sentimental modern sense. In scripture and in much of classical theology, the heart refers to the center of the person. It is the place of intention, of memory, desire, of decision, conscience, and relationship. This broader understanding is important. A hardened heart, as we call it, a hardened heart means resistance at the core of the person. A broken heart points to interior disintegration. Purity of heart refers to integrity. And St. Augustine, one of the fathers of the church, his restless heart, he points to a person oriented beyond immediate satisfactions toward deeper fulfillment, deeper desires. The heart then is where the person gathers. It is where cognition, desire, memory, and valuation meet. In that sense, it is a profoundly integrative symbol, holistic symbol. And symbols matter in healthcare because patients do not live by physiology alone, as we know. They live by the meanings through which they interpret their physiology. We know from clinical experience that what happens in the heart, in this wider sense, affects the whole person. Fear changes breathing, pulse, and sleep. Grief affects appetite, concentration, and pain, experience of pain. Shame isolates, whereas hope mobilizes. And trust in the treatment, trust in the physician treating me, can make treatment bearable. I'm not saying that all disease originates in the heart in a moral or spiritual sense. That would be both bad medicine and bad theology. I'm saying something more modest and more important. The lived heart is one of the places where illness becomes personal. It is where facts become fate and diagnosis becomes biography. A patient does not only ask, what is wrong with my body? Very often, even when not spoken out loud, the patient also asks, what is happening to my life? What does this mean? Can I still trust? Can I still hope? These are heart questions, questions of the heart. They are not reducible to emotion alone. They concern the unity of the whole person. In theological language, the heart is also the place where truth is either welcomed or resisted. Illness often forces human beings to confront truths they would rather not face, such as finitude or dependence or guilt, mortality, and the painful limits of control. We love control, but we are not in control. All right. Second, the brain. Indispensable, powerful, and not the whole story. Let me turn now to the brain. We live in what René has called, and when I spoke with him, a neurobiological age. The brain fascinates us, and rightly so. We're all looking forward to Dr. Newberg's lecture later today. Neuroscience has transformed our understanding of memory, affect, regulation, trauma, attention, decision-making, and social interaction. It has corrected naive dualisms and shown in a compelling way how deeply mental and spiritual life are embodied. Theology should welcome this. Any serious theological anthropology today must take the brain seriously. There is no human thought without neural mediation, no prayer without a living brain, and no hope without a living organism that carries it. That is important to say clearly because theology has at times spoken too easily as if spirit and body could simply be separated. In practice, serious illness, dementia, depression, exhaustion, and trauma all remind us that spiritual life is not floating above biology. And yet another question immediately appears. Does acknowledging neural mediation mean that the person then is nothing but the brain? Theological anthropology answers no. To say that consciousness is mediated by the brain is not the same as saying that the person is exhausted by a neural description. A love letter can be analyzed as ink on paper, but that does not tell us what it means. Likewise, an fMRI scan may correlate with prayer, grief, or moral reflection, but the scan does not capture the full reality of what the person is living through. Neuroscience can show conditions, correlates pathways and dysfunctions. It is powerful precisely there. But it does not by itself settle questions of meaning, of personhood, forgiveness, hope, dignity, or ultimate concern. In recent decades, we have seen the rise of terms such as neurotheology, which is also on the theme this evening. Neurotheology. Such work can help us tremendously understand how spiritual practices are embodied. But theology must also voice a caution. A correlation between spiritual experience and brain activity is not a refutation of spiritual reality. If the whole person is embodied, then of course spiritual life will have neural correlates. To discover that prayer involves the brain is no more surprising than discovering that seeing involves the eyes. The real question is not whether spirituality involves the brain. It certainly does. The deeper question is whether a person can be adequately described at only that level. And here, theology can contribute a language of irreducible personhood. The patient is not an object in whom processes occur. Patient is a subject who suffers, interprets, and hopes. The patient has an interiority that cannot be fully objectified. And I don't know anybody who has made brain scans to explain such a thing as prayer, for instance, who has claimed such a thing. This is especially clear in dementia and psychiatry. When memory fades, or when depression, trauma, or psychosis alter thought and affect, the questions quickly becomes anthropological. Who is the person now? Theology insists that dignity cannot be equated simply with present cognitive performance. The person remains someone and not something, even when expressive capacities diminish. At the same time, theology should not oppose neurobiology. Many patients need medication and meaning, therapy, and prayer. This is not confusing things. It is simply a recognition that the human person exceeds every single explanatory frame. Next concept is the concept of spirit, transcendence, relation, and ultimate meaning. Let me turn now to this third term, spirit. This word can make professionals uneasy. The same with spirituality, because it is broad, it is elusive, and it is used in different ways. Sometimes it is used religiously, sometimes existentially, sometimes as a vague synonym for inwardness. So we need some clarity, or we need at least to agree that there is ambiguity. When I speak of spirit here, I do not mean a ghostly substance, nor do I mean something opposed to the body. I mean the dimension of the human person through which we are open to what transcends immediate survival and immediate utility. Spirit refers to the human capacity for ultimate concern. It is seen in our search for meaning, conscience, truth, reconciliation, and the question of what we ultimately belong to. Spirit is also relational. It concerns how I stand before others, before suffering, before death, and for the religious person before God. This is why spiritual questions become especially acute in healthcare. Illness exposes finitude. It interrupts routines. It humbles autonomy, and it reveals dependence where there is. It places the person before limits that cannot simply be solved by technique. At such moments, patients may ask, why me? What remains of me if I lose my function? Am I still worthy if I become dependent? Can I forgive or be forgiven? What am I hoping for now that I'm so ill? And for believers, where is God in all of this? These questions are not marginal. They often shape the way patients live their illness. For theology, Spirit also names the human openness to being addressed from being beyond the self, from being addressed from transcendence. And this is difficult to translate into secular language, but it matters. A purely self-enclosed anthropology struggles to explain why humans so persistently orient themselves toward truth, goodness, beauty, forgiveness, and transcendence, even when doing so costs them. Spirituality and healthcare could not be reduced to techniques of calm or resilience. It's not enough. Those may be valuable, but spirit concerns more than inner regulation. It also concerns truthfulness, forgiveness, hope, and belonging. Many patients suffer from unresolved guilt, from concept that is being more and more important in research, moral injury, or the inability to forgive. These experiences are not adequately addressed by a purely symptom-based model. This is where spiritual care, and pastoral care, and psychologically informed existential care all have an important role. They remind us that the human person is not merely trying to regulate distress, but to interpret the life one experiences and the illness one experiences. Next point is the anthropological unity of body, soul, and the living person. If we are to speak of heart, brain, and spirit together, as I argue we should, we must ask more directly what theology on earth means by the human person. And here I allow myself to speak from my background of Christian theology, but I could also represent other approaches. But this is my perspective here this afternoon. One persistent misunderstanding is exactly that Christian theology simply divides the person into separable components, as if body were one thing and soul another, loosely thrown together and attached for a time. Some historical strands of Christian thought have indeed spoken in ways that invited this misunderstanding. But the deeper mainstream of Christian anthropology is more unified than that. The biblical view is not of a soul using a body as an instrument. The human being is a living unity. Breath, flesh, heart, mind, and spirit are different aspects of one life before God. This means first that embodiment is not accidental. The body is not a disposable shell. The body is intrinsic to personhood. It is through the body that we encounter the world, love others, that we speak, work, suffer, and receive care when we are ill. Second, spiritual life is not disembodied. It is never disembodied. Belief, prayer, despair, hope, trust, and fear are lived by embodied beings. Human beings are embodied beings. And this should make theology humbler and more attentive to medicine. Third, no single dimension can claim exhaustive explanatory priority. To describe the human being biologically, psychologically, socially, or spiritually may be true. but each description remains incomplete when it is isolated from the others. A holistic anthropology, therefore, does not abolish distinction, but it resists separation. This tradition also has something important to say about dignity. Modern societies often equate dignity with autonomy, productivity, or control. And theology reminds us that dependence is not the opposite of dignity. But if dignity is intrinsic to human beings, then care for the dependent person becomes not a concession to failure, but an affirmation of truth. This is not only anthropological, it is in its essence ethical. If human worth is tied too closely to autonomy or to capacity, to agency, then very frail lives can appear as lives of reduced value. A theological anthropology resists that conclusion. It insists that dignity is not lost when control is lost. For that reason, questions such as euthanasia and physician-assisted suicide cannot be approached only in terms of choice. Theological anthropology also understands the person as fundamentally relational. We become ourselves through family, language, community, those we love, and for believers, also God. Many illnesses would not only be bodical function, but lie in relational identity. Patients ask not only, what can I still do, but rather, who am I now for others? And next point 6 is illness as fragmentation, healing as reintegration. Let us now bring together heart, brain, and spirit. One of the things illness often does is to fragment the person. The body no longer cooperates. The mind becomes preoccupied. Relationships are strained. Identity is threatened. The person may feel alien to himself or herself. This is true in somatic illness, but it is also true in psychiatric illness, where persons often feel that they have become strangers to themselves. In both cases, the deepest suffering is often not only pain or dysfunction, but rather disintegration. From a theological point of view, healing is therefore more than cure. Healing is much more than cure. Cure is immensely important, and we should never romanticize suffering. That's not my agenda. When medicine, surgery, psychotherapy, or palliative care relieve suffering, these are goods to be celebrated. But healing is broader. Healing has to do with the restoration of a livable unity. Patient may not be cured and yet may still be healed in important ways, reconciled with family, freed from crushing guilt, able to hope again, able to accept care, or able to die in peace. Conversely, a patient may be technically cured and yet remain deeply unhealed. Bitter, isolated, and existentially lost. That is to be unhealed, in my view. This distinction is one of theology's most important contributions to healthcare. In the Christian tradition, salvation and healing have often been closely linked, not because every illness is miraculously removed, and not because faith abolishes medicine, but because the deepest human problem is not only dysfunction, it is rather estrangement. Estrangement from self, from others, from meaning, and for the believer from God. This does not mean that clinicians must adopt theological language. It means that healthcare should leave room for dimensions of healing that exceed repair, that exceed cure. The distinction is especially important at the end of life. There are moments when curing is no longer possible, but healing remains possible almost to the end. Presence can heal, forgiveness can heal, ritual can heal, human touch can heal. Being seen as a person and not as a failing organism can heal. So healing is this unity that unites. Next, at this point, a warning is necessary. Whenever theologians speak about meaning in suffering, which I'm doing now, we risk being misunderstood or worse, becoming harmful. Suffering should never be explained too quickly. Illness should never be moralized. Patients should never be told that their pain was sent for a hidden higher reason that others can identify on their behalf. This may be truth for some patients, but it's important that theology not tries to impose this. One of the most dangerous forms of religion in healthcare is precisely this, when theological language is used to silence lament, to bypass grief, or to impose coherence where there is actually terror in the patient. A mature theology, therefore, a mature theology of suffering, therefore, begins with realism. It allows protest, tears. It allows Job, or Job, we say in English, the Psalms, and Christ's own cry from the cross. Theology at its best does not deny suffering. It rather gives language for facing it. This matters greatly in clinical settings. Some patients experience faith as a profound source of strength. Others experience spiritual struggle, anger at God, guilt, sometimes shame, or the sense of divine absence. Such struggles are real and can worsen distress, and they should not be diminished or put into a bracket that this is something that's just to do with dysfunction in the theological sense. So when I speak of spirit as a resource, I do not mean that spirituality is automatically helpful. It can heal, but it can also wound. It can integrate, but also fragment. And in this department, much depends on the images of God, of self, of illness and hope that the person carries. The older theological tradition can help us here when read carefully. At its best, it knows that suffering is not an idea, but rather an ordeal. It knows that no theodicy, the problem of evil, can be spoken over another person's pain as if it solved it. It knows that lament is not a lack of faith, but often one of faith's most truthful forms. In clinical and pastoral settings alike, the task is therefore not to force meaning, but to accompany the person in the search for meaning or in the honest confession that meaning is currently inaccessible. Presence comes before explanation. Compassion comes before interpretation. Let me now become more concrete. What might this holistic anthropology mean in practice? First, treat the patient as a subject, not only as a case. The patient is not only someone who has a condition, the patient is someone to whom something is happening. Second, allow room for the patient's heart language. Heart language. Patients often speak in metaphors. I feel broken, or I cannot carry this, or I have lost myself. Such language should not be brushed aside as imprecision. It often communicates the deepest truth of the illness experience. Third, take the brain seriously without reducing the person to the brain. Medication, neuroscience, and psychiatry are essential, but patients also need interpretation, relation, and an experience of dignity. Explanation alone does not equal consolation. Fourth, include spiritual assessment where it is appropriate. And I think you all know the concept of spiritual assessment, asking simple, respectful questions that may be transformative. For instance, what gives you strength? What worries you most? Are there any spiritual or religious beliefs that matter for your care? Are there beliefs that make this harder? And fifth, build interdisciplinary cultures. No single profession sees the whole patient. Holistic care requires cooperation among medicine, nursing, psychology, psychiatry, chaplaincy, and then, where relevant, community or religious resources. Sixth recommendation, distinguish cure from healing. This helps especially in chronic illness, but also in psychiatry, rehabilitation, and palliative care. Even when disease remains, the work of healing may continue. Seventh, protect the dignity of the dependent person. Dignity is not lost when independence is lost. This is crucial in the care of the elderly, the cognitively impaired, and, of course, the dying. It also matters ethically because our understanding of dignity influences how we think about end-of-life questions, including euthanasia and physician-assisted suicide. Eighth, recover the importance of presence. In highly technical healthcare systems, presence may seem inefficient, but often it is one of the deepest forms of care. Ninth, attend to moral and relational wounds. Some suffering is intensified by guilt, by unresolved conflict, shame, betrayal, or loneliness. These are not merely extra concerns. They can shape the patient's ability to cope, to trust, and to heal. And 10th, remember that spiritual care is not only for the religious patient. Many patients who reject institutional religion still wrestle with questions of meaning, of belonging, forgiveness, and hope. And a holistic approach leaves room for those questions without requiring necessarily confessional language. Now, let me conclude. The theme of this conference joins three powerful words: heart, brain, and spirit. From a theological perspective, these should not be treated as competing explanations of the human being. Rather, they are different windows into one and the same mystery, the human person. The heart names the center where life is interpreted and gathered. The brain names the embodied complexity through which thought, emotion, memory, and action becomes possible. The spirit names human openness to meaning, transcendence, conscience, and hope. Illness often tears these dimensions apart in lived experience. Healing, in the deepest sense, has to do with their reintegration. This is why a holistic anthropology remains so necessary. Thank you very much.